very good morning to all of you. Welcome to the GMO Academic Program. Let me introduce today's lecturer. Today's topic is facing the challenges of deaths due to tuberculosis in Sri Lanka, the role of the medical officer. The lecturer today is Dr.Neranjan Dissanayake, who is president of the Sri Lanka College of Pulmonologists and consultant respiratory physician attached to Kaluthara. Dr. Dissanayake has contributed in developing national policies and strategies in tuberculosis as a member of advisory committees and technical support groups on tuberculosis for Ministry of Health Sri Lanka. Furthermore, Dr. Dissanayake has shared his expertise in developing national guidelines on TB, latent TB, and pediatric tuberculosis as well. His academic career also have yielded numerous international publications related to TB and also respiratory medicine. So let me warmly welcome Dr. Neranjan Dissanayake for today's lecture, and let's listen to Dr. Neranjan. Over to you.
Thank you very much for Dr. Kohmagate for coordinating this activity, and I would like to thank the academic unit of the Government Medical Officer Association for providing this opportunity. And Oscar Wilde, one of the greatest teachers of medicine, once said that William Osler said that a doctor dies the day that he stops learning. And I think as medical professionals, we have our obligation to keep our knowledge updated so that we will give a better service to our people. So today's topic is very interesting and important because it is very pertinent that we discuss about tuberculosis today, not only because we have the World Tuberculosis Day on the 24th of March, the day which Robert Koch published his findings on the acid fart staining and how to identify tuberculous bacilli as the cause of tuberculosis, but because in the Sri Lankan perspective, we still struggle hugely in battling this plague in Sri Lanka. Hence, we as the medical professionals has a huge task ahead of us in stopping or controlling this infection that is spreading in Sri Lanka. So let us first look at the Sri Lankan perspective. We know that tuberculosis has been there for centuries and millennia with the human race, but when we look at the literature for Sri Lanka, the first verified report regarding tuberculosis in Sri Lanka comes in about 1803, where it is reported that 4,000 Mozambique army volunteers who were brought to Ceylon by the British to fight the wars, have about 91% of them have died by 1820, within about 15 years, due to tuberculosis. So probably we had, as a country, a significant proportion of patients dying, people dying from tuberculosis even in the 1980s. But in the 1900s, the colonial government at that time understood the importance of tuberculosis because about 4,000 patients or people were dying because of tuberculosis by the 1900s. And this was causing a significant drain in their income as well as the other problems that they have faced. Hence, they have started the National Tuberculosis Committee, and then they actually by 1950 they were able to implement some very good strategies in Sri Lanka to mitigate the impact of tuberculosis. One such strategy is starting the chest clinic in every district with the help of the Colombo Plan by the Australian government by 1950. The second important thing is they made available widely the radiologic investigations, that is chest x-rays, which was rather new at that time in the world as well. And the third thing is they were made available the treatments that were available at 1950 to the people in Sri Lanka. it was a time where streptomycin was developed in 1944. So we were starting to treat tuberculosis with drugs by 1950. And they had a very good social network to cover the patients at that time. So we can think that by 1950, actually, we had a very good plan of managing patients with tuberculosis in Sri Lanka. And because of that, even though we lost about 4,000 patients per year in the year 1900, by 1956, this was a study done in the Court area in Colombo, they have identified that the incidence of tuberculosis, the estimated incidence was about 1,100 per 100,000 population in Sri Lanka. That's a large amount, but from deaths of 4,000, the incidence was about 1,146. And by 1970, we were able to reduce it up to 743 per 100,000. And that means that we have mitigated the spread of tuberculosis, and with that the death rates also came down to acceptable level. So we had a very good health system in place with regards to tuberculosis, and with the development of the country, we were able to control tuberculosis in an appropriate way. But by the year 2000, we were able to bring the tuberculosis number, the incidence, to an estimated value of 62 per 100,000. That's about 14,000 cases per year. So we were talking from about 4,000 deaths per year, we were able to bring down for about estimated amount of 14,000 cases per year. So see, we are a moderately burdened country, not a high burdened country in Sri Lanka anymore by the year 2000. But since 2000, we have huge problems in controlling, achieving our aims in tuberculosis. Because since 2000, you will be able to see this graph here, in the right side corner of your computer. We are, the incidence is not dropping. The black line is the case detection is going down, and the NTB target, which is about 10 per 100,000, we are far from achieving it for the past 24 years. So we are in a bit of a stagnated area in this regard. And when you look at this graph, you can see that as a country, from the year 2000 up to 2018, we can't be really happy, because our treatment success rate is about 85%. That means the number of patients who have been started on anti-tuberculosis treatment, only 85% are successfully treated with the outcome. And and one of the most important things is that about 6.4% have died in 2018. That means about 1 in 20 to 1 in 15 per people died with tuberculosis in Sri Lanka, even though we have all the facilities to treat them with the appropriate treatment. It is given free, and we don't have drug-resistant tuberculosis in Sri Lanka. We don't have HIV tuberculosis in Sri Lanka, but we have a low treatment success rate, and we basically have a high death rate. Why is it? And here the picture becomes more bleak. So we can see here that in 2022, we have about very high amount of death rates. About 747 people have died with tuberculosis, and that is about 9% of the people who have been started treatment with tuberculosis. So that is a significant number. Now, to put it in context, if you think that, if you look at the dengue deaths in Sri Lanka, it is not much as high like that. But there is a huge push towards eradicating dengue and controlling dengue, and that should be the case. Even a one death is important. But when we look at the tuberculosis death, that means that every 1 day, at least about 750, that means every 1 day, at least 2 people die with tuberculosis somewhere in the country. That is from the people who have been already diagnosed with tuberculosis and on treatment with tuberculosis. But we know that there are about 4,000 people that are there in the community who have not been diagnosed and not been started on treatment. Then out of them, probably 1 or 2 also may be dying. So we are probably losing about 3 patients per day with tuberculosis in Sri Lanka. And you can understand the immense gravity of this problem. So if, for example, with dengue or leptospirosis, 3 patients started to die from tomorrow in Sri Lanka, we know the huge commotion that will happen in Sri Lanka. But unfortunately, when these people die, there is no such, acknowledgement of their deaths. And that is one reason that we should, as medical professionals, push forwards to reduce these deaths in these people. Next slide. Go with that. This one. Stuck. Thank you. And when you look at the TB deaths in the nearly 5 years, we can see that the TB deaths, the percentages are rising up to 2022, as I said. Now, when we look at the age categories that with the patients who are dying, we can see that the 50% of the patients who are dying with tuberculosis are less than 65-year-old patients. And you can see that the range from about 0 to 14 years, one patient had died. That means children are dying with tuberculosis. And then we have the 35 to 45 range group, as well as the 55 to 64 age group. So most of these patients are in their prime of their lives, and they are dying because of tuberculosis. They are the productive group of the community. And so I think basically we have to address this issue, because people are dying, and young people are dying as well with tuberculosis. And when you look at the gender distribution, tuberculosis is commoner in males, as I expected, and the death rates are higher in males. It is sometimes attributed to the smoking and other habits that they do, but these males in a family are the breadwinners of the family. They can be, the father can be a farmer, even a doctor, but he's earning the money for the family. And you can imagine when these people die, what will happen to the family. So deaths in tuberculosis doesn't only cause a medical issue, it can cause a social and a psychological and economic issue as well. And when you look at this graph, you can see the yearly deaths of tuberculosis patients. And when you look at them, you can see that the shifting of the age group from the elderly people to the young people. And the peak is now at 46 to 60 years at 2022. So more young people are now dying with tuberculosis. So that is a huge problem that we have to address, right? And the unfortunate thing is that when we look at the deaths by treatment category, and we know that when we are starting treatment, tuberculosis treatment, if for the patient presents to us with the first time and this patient doesn't have any drug resistance, we usually start the patient on the 4-drug regime, that is rifampicin, isoniazid, pyrazinamide and ethambutol. And that is what we call the new treatment regime. So there are some people who can recurrence of tuberculosis, where there are different regimes that we use. So when we have different regimes, the new retreatment, the risk of multi-drug resistant tuberculosis as well as drug interactions are high. But unfortunately, we can see that 90% of the patients who are dying are newly diagnosed tuberculosis, not the retreatment ones, not the drug resistant ones. So that is a huge issue, because this type of tuberculosis, new tuberculosis, can be completely treated successfully with the 4 drugs that we have at our armamentum. But when we have these type of efficacious drugs, we still lose a lot of patients with tuberculosis. And when we look at the TB deaths by the type of tuberculosis, we can see that the smear negative tuberculosis patients have died more, and you can see a lot of extrapulmonary tuberculosis patients dies. And majority of these extrapulmonary tuberculosis, the death rates are very high as expected in TB meningitis. In Sri Lanka, the death rates are about 45 to 47%. That means every 2 patients with TB meningitis, sometimes one of them dies. And other having a poor prognosis is TB of the spine, where we have 1 in 5 people dying. So we can see that whatever the organ that is involved in tuberculosis, be it pulmonary, extrapulmonary, these death rates are high, right? And when we look at the comorbidities that are associated, why these patients are dying, we can understand that diabetes contributes to a major factor. So these patients, 60% of them have diabetes as a comorbidity. right? And most of them have poorly controlled diabetes, HbA1c more than 8, and some of them have HbA1c more than 10. So when you have diabetes with you, you can have a higher risk of getting tuberculosis, and the complications of tuberculosis are also high. And when these patients are analyzed, we can understand that these patients with diabetes have already nephropathy and abnormalities in their kidneys, and some of them have chronic renal failure as well. So diabetes is a very important factor that is contributing to the TB deaths. So hence, control of diabetes in Sri Lanka not only helps us to reduce the non-communicable disease in Sri Lanka, that is very important, but at the same time, it will be helping us to reduce the communicable diseases in Sri Lanka as well, because about 10 to 15% of our patients are anyway diabetic. So in a diabetic, we have to be very careful and suspect early whether this patient is having tuberculosis. So these are the some death investigations that we did in Ratnapura when I was there, and I would like to thank the Dr. Buddhika as well as Dr. Buddhika, our district tuberculosis officer, as well as our medical officers for providing these details. This is just to tell you the spectrum of people who are dying with tuberculosis, just to get an idea so that you will be able to understand. So the 58-year-old male who is COPD with alcohol liver disease, we have a 56-year-old male dying with meningitis, and then we have a 59-year-old patient with hypertension dying with a cardiorespiratory arrest, maybe unrelated for tuberculosis. And we have this 60-year-old patient dying with diabetes as CRF, 4-year-old patient dying with pneumonia, and then 72-year-old patient with a cerebrovascular accident, not related probably, but he has retroviral disease as well. Now this is another concern that we have. Retroviral disease is now rising its heads, and when you have retroviral disease, HIV plus tuberculosis, the prognosis is very poor in our patients, right? And then you can see hepatorenal syndrome, pulmonary tuberculosis, poorly controlled diabetes. So when you look at these deaths, we can understand a lot of comorbidities that are there in the patients. But at the same time, you will appreciate that most of these patients are actually around the age of 35, 45, 55 years. Hence, it is very important to understand that anyone can die with tuberculosis. Not only the old people, not only the elderly people. Right? So, to mitigate this effect, I think the first important thing that we have to understand is understand what tuberculosis really is, and that is one of the major things that I want to give it to you today. So when you look at tuberculosis, tuberculosis has been there since the Neolithic age in our community, right? So the human has actually evolved. Right? Humans have evolved from Africa to the Mesopotamian region and throughout the world and spread. And like that, tuberculosis bacilli has also evolved with us. And one of the major features of the tuberculosis bacilli, its thick wall that is surrounding the bacteria. So this thick wall gives it the capacity to withstand our immune system and resist our immune system. So this bacterial cell wall can actually help the tuberculosis bacilli stay in the macrophage, in the acidic environment, in the milieu of the acidic environment, without being destroyed by our immune system. And because of that, these macrophages, when they travel from the lung, which is the route that is infected, can travel basically to the brain, to the bones, to the gut, anywhere in the body, and hence these actually macrophages, which are there to help us defend against tuberculosis, act as vehicles of tuberculosis bacilli because of this nature that they can, there will be difficulty in eradicating. And because of this thick wall in the bacteria, unfortunately, these bacteria will be staying in our body for a very long time. Right? And this is a beautiful graph that I would like to show you, and I think it is very important to understand tuberculosis in this context. Right? When you are infected with tuberculosis, now if you are, for example, if you are infected with Streptococcus pneumoniae, a bacteria, what happens is our immune system will get activated, it will destroy the bacteria, and then you will be cured. And after that, you will be okay. You will not have a risk of having the disease due to the same infection. But when you look at tuberculosis, the unfortunate thing is that when you are getting infected, right, if your immune system is poor, right, if your immune system is poor, what happens is you can get infected in the primary infection, that is called primary tuberculosis. So it's like a pneumonia. Especially this happens when your immune system is very, very immature, like when you have HIV, or especially the children less than 1 year. So these children who are less than 1 year are at high risk of developing tuberculosis, especially if their mothers and other contacts are infected with tuberculosis, and they can develop a pneumonia-like picture, a severe pneumonia-like picture due to primary tuberculosis. But in majority of us who have a good immune system, this bacteria can be contained to a certain extent, and then sometimes it can be completely eradicated. But the beauty of the tuberculosis bacilli is that they can keep hiding in our body and wait. Right? Our immune system has seen the bacteria, hence the MAN2 as well as the IGRA will be positive in our body, but we will not have the active disease. That means we don't have the symptoms of tuberculosis. We don't have the serology. ESR and CRP will be normal. Radiology will be normal. The biopsy will be normal. The microbiology will be normal in these patients. They will be completely normal, but they have an immune reaction towards tuberculosis, and that is what we call latent tuberculosis. And these people have the tendency to harbor the bacteria in their body to a long time. But what happens then? So we might be infected today with tuberculosis, but we don't know from a person who is just sitting in the AC bus next to you, but you will get the disease probably in about 10 years or 5 years. The risk is highest in the first year and then lowest in the second year, right? But again, you can get the disease after some time, right? And when this happens, you can have a rapid reactivation. For example, you are completely normal now, but you start to take TNF alpha or steroids and the immune system goes down, then you can have a rapid reactivation. Or else, you can have a slow reactivation, especially we see this in the elderly group. So you are infected, the patient is infected, but you are gradually deteriorated, and you can see some elderly people coming with cough probably lasting for about 4 to 6 months, and you can see that the lung is completely destroyed. And some of them will die with later TB, they will not have the active disease, and sometimes our body will be eradicating the disease. So TB has lot of phases. So if your enemy has one phase, it is very difficult, it's very easy to control, right? For example, COVID had one phase, and we are not now worried about COVID anymore, even though we had a lot of issues with COVID, right? But with tuberculosis, you have multiple phases. And when you try to manage these patients, it is very difficult to manage these patients, right? So these are some pictures that I would like to show you the consequence of having tuberculosis. The classical example is pulmonary tuberculosis, where you see the upper lobe distribution, cavitatory lesions, nodule lesions. I'm showing these x-rays to our medical officers because chest x-ray is a very important tool in diagnosing tuberculosis. And even if you're in the private sector, even in the OPD, don't hesitate to take a chest x-ray, right? And we are trying to push for the rights of OPD doctors to get the chest x-ray, and hopefully we will be able to get it done very quickly, because any patient, if you are suspecting tuberculosis or for that any lung disease, and if you see abnormal signs, it is always better to get a chest x-ray and have a look, right? So because you will be diagnosing not only TB, malignancies and many other things, right? So tuberculosis, chest x-ray is a very important thing, especially if the patient is having respiratory symptoms. And these are the types of chest x-rays that you might come across, right? And when you look at the morphological appearance, this is what the tuberculosis bacilli can do to your lung when you have upper lobe cavitations. You can identify the immense damage that the TB bacteria can do to the lung. And when your lung is completely damaged like this, it is really, really difficult for it to heal. And in these damaged areas, there are a lot of bacteria that can grow. Some of them have fungi, and you can have mycetomas that are growing, and then you can have bleeding because of the fungal infection. So it is not a simple process. Even if you have tuberculosis, we are cured of tuberculosis. Sometimes these consequences can go a long way, right? Sometimes tuberculosis can masquerade as tumors. You can see that there's a superior mediastinal mass with a left lung opacity, and this was actually tuberculosis. And this is the typical appearance of miliary tuberculosis. Now, miliary tuberculosis, this is a clear picture, I know, right? So you will never miss this, but sometimes these miliary mottling are very, very subtle. So when you take an X-ray, always put it to an illuminator and have a look at it, or else you will miss. Right? So when I was in Badula, I had a patient who has been treated in a hospital in Colombo, and about 3 months before, there were miliary mottling in this X-ray, but this patient had been treated for generalized body pain, and when the patient came to us, she was with a reduced unconscious level, and the chest X-ray showed miliary mottling. But when we look at the 3 months before X-ray, there were some miliary mottling. So it is very important. We are not trying to, put the blame, but it is very important not to miss these subtle signs in chest X-rays. So always put the chest X-ray on a illuminator and have a look at it. And I would like to stress more and more about the importance of the chest X-ray, because as a doctor you have a right to order a chest X-ray, and there is no one preventing it, right? Especially be careful when you prescribe X-ray in a pregnant patient. But even then, if you have a high suspicion rate, if you are taking the adequate precautions, even there is no contraindication, but you have to balance the risk and the benefit. But here, in the correct clinical context, a chest X-ray is mandatory in these patients, right? So cough is a very, very, very common thing, right? And one of the major factors of tuberculosis or presentation types of tuberculosis is cough. Actually, 91% of the patients with tuberculosis will have a cough. Pulmonary tuberculosis will have cough, right? So this is one patient actually which we had around 34 years. He had COVID, and then this patient came to us with intractable cough, right? So this patient was treated for COVID. She was completely well. The lung was completely improved, but she complained of this cough. So I went ahead and did this bronchoscopy, and you can see that in the bronchus there are multiple nodules that are there, and we thought that it is possibly a malignancy that the patient is having, but the biopsy came as tuberculosis. So this can present in many, many ways, and after the treatment of 2 months, we did the repeat bronchoscope. It was completely cleared. So cough is a very important symptom. If it is there, we have to investigate further, ideally with a chest X-ray and sputum AFB without delay, right? So this is another patient that was present to Ratnapura. This patient actually is an elderly lady, not elderly actually, she was about 56, I'm sorry, but she's 56, and she actually has gone to the cardiologist because the patient was having progressive shortness of breath. And he was emaciated, and actually our cardiologist referred this patient to us because the patient was having a pleural effusion. So this patient was having shortness of breath and been going from doctor to doctor for a long time. Fortunately, our cardiologists have seen this patient, and when the patient did an echo, have noticed the pleural effusion and then referred to us for the diagnosis. And this patient had what we call a trapped lung. You can see that the lung is poorly expanding even with the intercostal tube. So she had about 6 weeks of hospital stay, and fortunately at the end of the day we were able to make her comfortable. We couldn't remove the tube early because there was bubbling and the lung was poorly expanding, and she was not fit for surgery for decortication or anything, and so that we were able to manage. And you can see that even though the lung is completely white out in the left side, we were able to treat this patient appropriately. And this patient actually was diagnosed today, right? So just to highlight the importance of tuberculosis in these patients, right? So you can actually see This patient's HbA1c is 11.6, very poorly controlled diabetic with a good background. This lady was about 46 years, came to us with cough. And when you look at the chest x-ray, you can see 2 abscesses in this patient. And today, the sputum came as positive. So a person, whatever the background, whatever the social background, if a patient presents to us with cough, especially in the context of uncontrolled diabetes, be careful not to miss tuberculosis, because if you miss tuberculosis, the patient will give the disease to another person and her lung and all the other organs might get damaged. So in the context of poorly controlled tuberculosis, because we know that many OPD doctors, clinic doctors, endocrine doctors see patients, a lot of patients with diabetes with poorly controlled. But if you can't understand the symptomatology, cough is there, weight loss is there, non-specific symptoms, be careful not to miss tuberculosis. And please, if the chest x-ray has not been done within the last 6 months or 1 year, and if you are suspecting, ideally do a ESR, have a look at the chest x-ray, and do a sputum if you are suspecting tuberculosis, not to miss these patients. It's very, very important, right? So this is another type of presentation that we have, and you can see that in the right side upper zone, there is a bit of nodularity in this chest x-ray, and this is the bronchoscopy that we did in the morning, right? And you can see that this is full of blood, and this complete trachea is full of blood. And sometimes tuberculosis can present like this as well, the upper zone nodularity. We don't still have bacteriological confirmation in this patient to say that this patient is having tuberculosis, but this is definitely not a malignancy. So sometimes there are dramatic presentations that can come like this. And this is another patient who presented to us with a left-sided chest pain, and you can see that this patient is having what we call a meniscal sign. And especially when we are examining the patient, even in a private sector or OPD, listen to the basis of the lung. That is very important. If we see a reduction of breath sounds, this might indicate a pleural effusion. Go for a chest x-ray and have a look at it. And this is actually the thoracoscopy of this patient, and we can see that these effusions, when you look at the thoracoscope, you can see multiple nodules in this patient, and the biopsy was proven to be tuberculosis. So tuberculosis has many phases, right? And it can affect any organ. The ophthalmology doctors might get a patient with red dye, with anterior uveitis, with a mutton fat appearance in the slit lamp examination, or else you can get this serpiginous choroiditis, which is sometimes typical of TB retinitis. And then doctors who are doing urology surgery might get patients with abdominal pain, or sometimes even physicians or medical doctors with sterile pyuria. However you treat the patient, there is pus cells and red blood cells in the urine not improving, and then that might be an indication for TB of the kidney. And if you don't identify it, the patient might go into even renal failure. Lymph nodes are very common in our patients, especially in children. They might be matted and enlarged lymph nodes. So if we are having suspicion, we have to investigate and see. Sometimes TB osteomyelitis, when you have TB in the bone, this bone lesion can erupt and come through the skin and present as a chronic wound like this in this patient whom we had, and then you have to suspect TB osteomyelitis. Headaches, abnormal behaviors, seizures might be a presenting feature of TB meningitis. So we have to keep an open eye for diagnostic procedures. And if you are suspecting tuberculosis in any other organ, please take a chest x-ray to see, because the primary infection might already be there apparently in the chest. And there was actually a young lady in one of the hospitals who had mononeuritis multiplex recently, and there were investigations done. The ESR was high because the patient was awaiting to start methylprednisolone because of this one, but because of a mild cough that the patient had, did the chest x-ray, and chest x-ray showed full-blown tuberculosis, and the sputum AFB was positive in this patient. So we can have multiple clinical presentations, and that is why managing tuberculosis is very difficult. Skin tuberculosis is again a feature that we have to, even though it is not life-threatening, it can be disfiguring, and you can have erythema nodosum down here, and there is ecthyma. We had a recent lady with ecthyma where you can have shin lesions that are coming like that. And TB of the spine is another important aspect that we should never miss. A chronic back pain, especially in a young person, who has no other features. Sometimes these chronic tuberculosis affect areas which are already traumatized. So we might attribute that this patient was having a fall previously about 5 years back. That is why he's having pain. But if this pain is new, if it is affecting his daily function, if it is, if patients have fever, and do a ESR and have a look at it, and we always do an X-ray of the spine and see. And the typical feature of TB spine is the osteomyelitis feature, where you can see two adjacent vertebrae, being destroyed. It is different from destruction because of a malignancy, where you can have collapse of a vertebrae. And if you don't diagnose it, sometimes the patient can have complete paralysis of the upper or the lower limbs without even bladder or bowel control, and that will ruin the whole life of the patient, and it will ruin the whole life of the family as well. Right? TB of the gut is another important aspect. Change of the bowel habits, having blood in the stools is another important thing that we have to think about. Right? And especially in males, TB epididymitis, they might have epididymal pain, and some of them might have tuberculosis of the vas deferens, and when you have that, you might even have infertility. In females, you can have TB of the endometrium and the fallopian tube, and that might result the patient having infertility as well. So these patients might present to the infertility clinics as well. So we can understand the wide areas of tuberculosis. Now, this patient actually presented with a pneumothorax with tuberculosis because the tuberculosis has ruptured into the pleura, and this patient was actually, having a spontaneous peritoneal rupture of the gut. Right? So there are various types of tuberculosis that we come to know. You might be in the genomes ward, you might be in the surgical ward, you might be in the ophthalmology ward, you might be in the psychiatry ward. Right? Because in psychiatry, sometimes these patients' symptoms are neglected. Sometimes, unfortunately, when they say cough, we neglect that this might not be the correct thing. And especially when you have a patient who is having a psychological disease, specifically if the patient is having schizophrenia and other conditions psychologically, be careful not to miss these patients. Always think about tuberculosis in these patients, because if we miss them, we will be treating to something else. And sometimes these changing of behavior, if it is recent, might be due to a tuberculoma in the frontal lobe that the patient has. So we have to be very careful not to miss the organic pathology. So any specialty doctor who is listening, if you want, you will probably have a tuberculosis patient coming in front of you even the next day of your life. TB of the children is a very important factor, unfortunately, because the mother can give the disease to the child through the chorioamniotic fluid, and these patients can get congenital tuberculosis and may have a poor prognosis. So every child who is infected, the mother or the other adults are the responsible persons for giving this disease to a child. So something about treatment about tuberculosis. So we now know that tuberculosis can present in many ways, right? And some of you might come across patients who are already started on tuberculosis treatment. So it's better to understand about this, because some of these drugs have complications, and we have to know how to manage complications if you want to reduce the incidence of drug reactions. So tuberculosis is a beautiful bacteria where a single drug is not enough. They are actually behaving like multiple organisms in the single body, and because of that, we need at least about a combination of 4 drugs in the initial phase, we call intensive phase, of rifampicin, isoniazid, pyrazinamide, and ethambutol, which we give as a fixed drug combination. That is what we call FDC. And when you have 4 drugs, we call it FDC4. If it is 2, FDC2. And some of you will be coming across these drugs, patients who are on these drugs. So if it is FD4, that means this patient is on all 4 drugs. FDC2, that means 2 drugs, isoniazid and rifampicin. Because in the intensive phase, in the acute phase, we treat for 2 months with all 4 drugs in drug-sensitive tuberculosis. And then we extend the rifampicin INH further 4 months if it is simple pulmonary tuberculosis or most of the tuberculosis. But if it is TB meningitis, we extend it up to about 10 months, and if it is tuberculoma, we can go up to 18 months of continuous treatment. So it differs, but these patients will be on multiple drugs. So what are the main important side effects that we can think about to prevent death in this patient? One of the major side effects is rifampicin-induced DRESS syndrome, where the patient's eosinophil count go up and there will be a rash, and if you don't stop the drug, the patient will die. Rifampicin-induced thrombocytopenia, like flu-like symptom. If a patient has low platelet with while on rifampicin, stop the drug and seek expert opinion. Hepatic problems, sometimes if you don't consider that, it can go and develop into hepatic failure. Right? Those are the three important aspects, that life-threatening conditions that can cause, but there are many other side effects that we can deal on a daily basis. So any patients who is on these drugs, we should know the main side effects so that we will be able to identify them early. So what about controlling tuberculosis? Now, if we go according to the correct plan, we will have to live about another 4 or 5 lives to see TB eradicated from the world. But if we have a vaccine, we will be lucky. But unfortunately, most of these vaccines, as you can see, are still in the development, and fortunately some of them are in the phase 3, but most of them are still in development. And this is one of the best contenders for a good vaccine that will be coming out hopefully after the phase 3 trial. So there are good messages here that can be given. So what about BCG? You might ask. BCG is a very good vaccine. It is very old, but Bacillus commentiguri, or BCG vaccine, has the potential to reduce the severity of tuberculosis in children, reduce the severity of TB meningitis in children, reduce the incidence of disseminated tuberculosis in children. But in adults, it has not shown to be any benefit when preventing tuberculosis, right? So this is the type of patients that we get. Why do we get these type of patients, right? This is a 25-year-old person. You can see that the lungs are completely destroyed. His blood pressure was about 80/60 when the patient came to us, was oxygen dependent, right? So why this delay? Now we can understand that how we have to struggle to save these patients, and you can see that the patient is markedly emaciated, right? So we have to get our patients before this, right? These patients probably would have gone to a doctor before, right? So why are we missing patients? Now, when we look at the missing patients, this is alarming, and this should be alarming for all of us as medical practitioners, because when you look at it, there are 5,800 cases missing in 2022. So we'll estimate that, okay, 4,000 is missing, right? That means that out of which about 2,000 will have pulmonary tuberculosis, and out of which about 1,200 would have smear positive pulmonary tuberculosis. That means these patients have sputum positive tuberculosis. So you can imagine the danger to the society as well. So these patients, a smear positive patients with pulmonary tuberculosis, the first thing is, if they are not treated, 70% of them will die within the next 2 years, and they will have multiple comorbidities. And the other thing is, these patients who are having smear positive pulmonary tuberculosis can give the disease, if not treated, to at least 12 to 15 people per year. That is the calculated value in developed countries. But here in Sri Lanka, when you are going in a crowded bus, probably he might be able to give it to dozens of people. So tuberculosis is our responsibility as well, because as medical professionals, if we don't control tuberculosis, smear positive tuberculosis, if we don't identify them early, if we don't start treating them early, patients will have a bad deal. They will come like the previous x-ray, but at the same time, we are risking our children, our loved ones, of getting tuberculosis. We don't know. This patient who is missing might be now traveling probably from Goa to Colombo in a bus, and one of our relatives, maybe our mother, is sitting next to him, right? And probably our child who is now coming from the school now, the driver might be having positive tuberculosis, right? The home person who is looking after the children by us, because we are working, we have to look after our children in a different way. They might have tuberculosis. So, this risk is just propagating. It goes on and on and on. So we have a responsibility to stop. So should we change our screening strategy? Definitely yes, right? So when we have to have a standard screening plan, because we are in the medical profession, and some of you might be having an influence about the policy making area. If you look at it, in 2022, almost 1 out of 2 patients of tuberculosis in Sri Lanka is from the Western province, Kaluthara, Gampaha or Colombo district. That is 1 out of 2, right? And out of which, half of them are in the Colombo district. Not Gampaha, which has the highest population, but Colombo district. Out of which, half are in the Colombo municipal area, CMC area. So actually, every 1 in 8 patients in Sri Lanka with tuberculosis is in Colombo Municipal Council. So I think that is an important thing, and that is probably the hotspot that distributes tuberculosis to other areas. Maybe Nuwara, I worked in Nuwara, and then Badulla, Vavuniya, anywhere, probably that is the hotspot, because these areas are very congested. These people come from various parts of the country to work as anatomies, as kottubasas, construction workers, and that is an area that we should study. If we want to reduce deaths from tuberculosis, we have to target these areas and screen these areas. If there are community physicians or community physician doctors who are listening, I think this is an area that we have to target very quickly. So how else that we are going to miss? When a patient has tuberculosis, when you have a problem, the patient goes to, take treatment. Might be a medical doctor, might be a non-medical doctor, or sometimes indigenous treatment. But because of that, there is a significant delay. So as medical officers, as medical professionals, can we reduce this delay, right? So these are the studies that they have done, right? In Sri Lanka, actually, right? You can see that, when the patient presents, about 150, 20% is diagnosed within 1 week. But you can see that even after 1 month, a significant proportion of patients with tuberculosis are not diagnosed, even after coming to the health care system, right? So that is a significant problem, because even if the patient comes to us, we have a delay in diagnosis. So this delay is mainly there basically in the government hospitals sometimes, and especially in the private providers. It is not a blame game, actually. We don't want to blame anyone, and we don't want to say that district chest clinic is better, because district chest clinic is geared to identify tuberculosis. Even if one person has a cough, yes, we will do a chest X-ray and do the screening. So we will get the diagnosis early. And we know that in government hospital is very, very busy. In a OPD, there will be a huge amount of people, right? In private providers also, sometimes if we don't think about this diagnosis, we are hesitant to order X-ray. If we are hesitant to order a sputum, then if we don't think tuberculosis, then there will be certain delays, and you can see that there's a mean delay of about 26 days in private providers, and we have to actually address this very quickly. So how do we address? Identify the main system. If the patient is having cough, 95% of the time TB patients will come with cough. Fever will be another thing, low-grade fever. Loss of appetite, loss of weight, fatigability will be there. Hemoptysis, they come early, within 3 days, because it's an alarming feature to them, right? So patients will stay. So if you have a cough, they might stay about 21 days without seeking treatment. But if they have hemoptysis, they will come to you early. So we have to address this and understand this and identify these patients early, right? So these are the outcomes of the patients who have visited the private practitioner. When we are thinking about the TB patients, we can see that at the first visit, 1 out of 4 patients were diagnosed when the patient had tuberculosis, right? Out of the number not diagnosed, in the second visit, a further 1 out of 3 were diagnosed, and then 1 out of 5 were diagnosed. 1 out of 20 were diagnosed, and to diagnose all these patients, this patient needed to go 6 times to a doctor, right? I think that is one of the most important things that we have to think about here. So when the patient comes to us, this patient had to go again and again to a doctor to get the diagnosis done. So if this was done, and if we were able to refer this patient at the earliest onset to the district chest clinic, or if we were able to do a chest X-ray, do a sputum at the instance, right, or do at least a ESR chest X-ray and a sputum, then we would have probably diagnosed some of these patients. Not all. Some of these patients probably would have been diagnosed after doing even bronchoscopy, right? But significant proportion we would have been able to diagnose. So again, the message is we have to diagnose these patients earlier. Don't miss this opportunity when a patient comes to us as a medical professional, even a consultant, as a consultant or a medical practitioner in the OPD or in the private sector. Don't miss this chance. Think about tuberculosis, do the investigations and try to diagnose these patients, right? So that is the most important thing that we have to see. So we have a little bit of a flow chart. I don't think we are educated people, we don't really need flow charts. The most important thing is if you have suspected tuberculosis, a patient coming in cough, weight loss, you are not, especially when a patient is having uncontrolled diabetes, do a chest x-ray. Ask them to do it. Some of the times you can get an x-ray done by 1,500 rupees, 2,700, even in the private sector. And if you are worried, write a referral to the chest clinic. They will do the chest x-rays for you. They will do the sputum for you. They will even go for a gene expert for you. So that the patient will be diagnosed properly. And this patient will be thankful to you. Now that lady who was diagnosed today, even with a high family background, she was thankful for diagnosing tuberculosis because these patients, they now know the diagnosis. So they will not hesitate to come again to you for treatment for other ailments, right? So it is very important if you think about tuberculosis. He has found my disease. That is an important thing that we should not miss in these patients, right? Pediatric pulmonary tuberculosis comes in very different ways. They can come with poor weight loss, failure to thrive, and sometimes lymph nodes. And in these patients, if the child's mother or father or child has a strong contact history of tuberculosis, ask. If a child is not growing, poor weight gain, fever, mother and father always comes and says he's not eating, think about tuberculosis. Ask whether there are close contacts of tuberculosis in the family. Sometimes they will deny, they will not say, but ask again and again. Then we can diagnose, right? So that is the important thing that we have to think about. Then we will be able to prevent this type of patients coming into the hospital, and then we might be able to treat them early as possible. So some of the socioeconomic factors, right? So these are some examples of these patients. So these patients are poor most of the time, right? And we give the drugs, yes, free of charge, but they don't have a place to stay, right? And we send the patients with drugs and they don't actually have means to eat, right? So we are giving drugs, but they don't have adequate amount of nutrition. So now as a society, we have to provide appropriate care. This actually was done by Dehana, this study, the DTC trainee in Ratnapura. We can understand that when we keep patients in tuberculosis, 54% of them, about 50% of them are due to social factor. They don't have a place to go. They may have a means to eat, right? They don't have a way to, live without any support. And because of that, these patients should be managed. What if we send this patient out? They don't have a thing to eat. They will go to the job rather than taking the drugs, and they will default definitely. So we have to have, as a country, we have to understand this gravity and provide these patients appropriate care. These are some examples of these patients. Bacteriologically confirmed manual worker, unmarried, and lives in the OPD, and he was in the Gilimale hospital. And 32-year-old young patient, he's taking drugs and there's no place to go. And this patient, 68-year-old, schizophrenia, as I told previously, poor family support. So these patients, if you look at these patients' houses, right, they have very, very poor support, right? These are some examples. 33-year-old clothes seller at PETA, bacteriologically confirmed, father of 2 children. So imagine now this patient is a father of 3 children. They only have 1 room in their house, and we give the treatment and ask the patient to stay in a single room. How can he stay? Their house cannot contain them. So these are the social factors as medical officers or doctors that we have to consider. If we don't consider this, they will not come back for treatment. And by that, they will be doing themselves harm, their children harm, as well as the society harm as well. And we will have a high death rate that will be there, right? So again, 46-year-old will run radiculopathy. So we are able to change certain things. So we were able to develop some hospitals so that we were able to keep these patients in a long-term care. This is from Mahaliagoda, and I'm very thankful for the doctors there who have been working with me. We were able to develop these units so that the patients will have a better life there, right? And The other important thing, almost the last thing that I would like to discuss is that, okay, we have treated these patients with tuberculosis. Now, is it over? Does it help to reduce the death rate if we look after them further? So it is an analysis of post-tuberculosis bacterial patients in Ratnapura done by our DTCT trainee Janith. So here we can see that almost all patients, about 57% about patients have lung disease or lung damage due to tuberculosis when they come the first time. These are smear positive proven cases. So if we just treat these patients and send them off, this bronchiectasis will happen and they will have recurrent infection. And for example, these are the age groups. You can see they are very young people, 14, 34, 56. They are young people and they are in the productive age group. These people cannot work in the family and they can't earn certain things. And these people will not be able to, even if, imagine a 24-year-old girl who is awaiting to be pregnant. Sometimes she will not be able to have a child because he is having severe bronchiectasis and not properly rehabilitated. And these patients will have a poor lifespan and we will increase the deaths if we are not treating tuberculosis, right? So these are some case scenarios. This is actually a 50-year-old garment worker who is working in a garment. Completely lungs are destroyed. We were able to treat her properly, but the lung will be continuously damaged like this and she will have lifelong bronchiectasis. So we have to rehabilitate them properly into the society so that we can teach them exercises, how to physiotherapy to remove this phlegm that from happening, how to prevent the lung damage. It is very important, or else this patient will come in about another 3 years with the recurrent lung infection and then will go into pulmonary hypertension and this patient will die, unfortunately. 21-year-old girl, housewife, type 1 diabetes, look at this chest x-ray, completely destroyed, and you can imagine the poor outcome of this patient. 14-year-old student, right? Duration of symptoms only 1 month. There was only 2-week delay in presentation and you can see how the lung had been. These are true patients that I'm presenting to you. 35-year-old salon worker, you can see the amount of damage in the lung. Can you imagine, this patient probably have gone to about 3 or 4 people before getting diagnosed. So probably we are sometimes responsible, sometimes the patient is responsible, but there is a delay, and even after this damage is done, after we treat, we have to look after these patients. 76-year-old, especially elderly people, we sometimes neglect their symptoms and they can have lung damage and then further consequences of the lung damage, right? 61-year-old upper lobe obesity. So as medical officers or doctors or medical profession, being a house officer, RHO, medical officer, SHO, registrar, whoever, whatever the capacity are, consultant, whatever the capacity are, what can we do basically to end tuberculosis? I think the most important thing is to suspect tuberculosis in the appropriate clinical setting. Especially uncontrolled diabetic coming with cough, think about tuberculosis. A patient who is emaciated coming with cough, think about tuberculosis. A child, poor weight gain, contact history of tuberculosis, think about tuberculosis and arrange for investigation. Then we will prevent these delays from happening further. Then the rational use of diagnostic tool. I would like to stress again the importance of chest x-ray. Chest x-rays are not difficult to interpret. It is not rocket science, right? You are trained doctors, get a chest x-ray, right? Please get a chest x-ray. 1,500 to 2,700 rupees for the patient if it is the private sector, fully worth, and it is available freely in most of the areas of the country. So do a chest x-ray. OPDs, hopefully we will be able to get a circular done allowing the OPD doctors to do a chest x-ray if we are suspecting tuberculosis, and it will be there very soon. If you are in the other specialties, diabetes, ophthalmology, if you are thinking of tuberculosis, extrapulmonary tuberculosis, get a chest x-ray done. That is the most important thing. Sputum AFB, yes. Gene expert, if there are X-ray changes, still suspecting tuberculosis, gene expert is a very important tool that we can use. Ask your colleagues in respiratory medicine or chest clinic, arrange a sputum gene expert. It is done free of charge for the patient and we will be able to diagnose. MAN2 doesn't have a significant value in TB diagnosis. It is done to diagnose latent tuberculosis only. So don't ask for a MAN2 at the first instance, but we sometimes do MAN2 when we have other suspicions, because MAN2 says that you are infected, you have been earlier infected of tuberculosis. That doesn't say that you are actively now TB infected with tuberculosis. So chest x-ray, probably ESR, which are very cheap, and then sputum studies, then at least we might be able to diagnose pulmonary tuberculosis. But we have to think about other tuberculosis in the apparent clinical setting. Understand the complications that can arise due to the disease as well as the treatment, and identify them early, and then follow up and rehabilitate patients with tuberculosis. Now, what will happen if we can't control tuberculosis, right? So this is actually Switzerland in the 1800s. So the people who had money were able to go into the Alps and Alp mountains, and they had a nice time there. They had good food, good light, good ventilation. But can all of the people afford? And they probably died to a certain extent. But unfortunately, majority of the millions of the people died silently in slums. So that is the problem with tuberculosis, right? So the disease picked and few princesses. We might name few individuals who had died of tuberculosis, like Kafka, right? But majority, millions, have died silently because of tuberculosis. So it is very important to identify, and they are still dying as well. Even as we speak today, 2 or 3 people will die because of tuberculosis today itself in our country, somewhere in our country. So that is very important that we understand that. These are the innocent people that we are dealing with, right? They don't, have a proper place to stay, proper place to eat, right? And these are the areas that we have to think about. Try to diagnose as early as possible. Don't ask them to come in another day. Get the investigations done. Get the diagnosis correct, and we will start treatment appropriately, right? And I would like to end this with the Bertolt Brecht say that, especially when these patients comes to us, these are socially deprived people, but that doesn't mean that they are all socially deprived. We have to look into their souls, and they will tell us the problem that they have, right? And when you're talking about medical officers, I'm really, really fortunate to have some brilliant medical doctors working with me during the past years. So after I became a consultant, I first worked in Nuvarelia, and we were able to actually develop Nuvarelia. We only had a very small chest clinic room, and now we have a 3-story building. And we were able to develop into a ward as well now. So there were a lot of doctors working with me, and some of them are actually now consultants. Chanaka is a respiratory physician, and Upeksha is a microbiologist, and other doctors are doing well as well. Unfortunately, I don't have a photograph of them. Then I came to Badulla, and we were able to do a lot of things there. I think some of you might know, Lasita, Tanuja, right? So Dasita, and we worked together as a team, and we were able to do a lot of things. It is not an individual thing that we have to. And this is from the Haliagoda Hospital, Shashika, our medical officer there, and there's Janith, my DTCT trainee, and the doctors from the Haliagoda Hospital and the chest clinic, who have been immensely supportive for caring of tuberculosis patients in Haliagoda. And this is my beloved team from Ratnapura, whom I left. And we have Terence, who is actually now Ragama, we have Oshan, and we have Anusha, 2 Anushas, and then our RHO, and Dehara, Tivanti, and Darshana. So we all work together as a team. And these medical officers, and these are our chest clinic doctors in Ratnapur actually, Dr. Buddhika, Dr. Veeraman, and our doctors there. So we worked as a team in Ratnapura. At the end of the day, we were happy that we are doing something worthwhile. And I'm sure in the medical profession, that is one thing that we can be happy about, caring for patients with the most appropriate way. Right? And with regard to tuberculosis, if you are able to prevent a single death in our country with tuberculosis, we have almost around 15,000 medical officers in Sri Lanka, isn't it? Right? So if we have that approach, at least if we can prevent one death or diagnose early one patient with tuberculosis within this year, probably we will be able to diagnose most of these people within 2 or 3 years. So I wish the very best to all of you, and I again thank the academic committee of the Government Medical Association, which I'm a proud member as well, for giving me the chance, and especially Bodhika as well. And hopefully it was useful, and if there are any questions, I'll be happy to answer. Thank you very much.
Thank you very much, Dr. Neranjan, for that interesting lecture. And I think the World TB Day falls on 24th of March. Can you please tell us what is your message for World TB Day?
Yeah. I think the most important message is that, as you said, World TB Day, we can't, take everything into a day, and it should be a planned process where we work each and every day so that we will have a better outcome for our patients. And this time, the World TB Day, as I earlier said, it commemorates the day that Robert Koch discovered and presented his findings about tuberculosis bacilli, and it gives us a chance to rejuvenate and get together and talk about tuberculosis. And that is one reason that we are doing the lecture with the invitation from Dr. Bodhika, our beloved past president of our college, who has done tremendous work for the College of Pulmonology. And I'm sure that to the GMA, he will be a great asset, and for the medical profession as well. I wish him well as the council, as well as the ESCO. But, we have to have a plan that is throughout the year, and hopefully this will be the beginning of that year-long plan.
Thank you very much again, Dr. Neranjan Dissanayake, and thank you for your participation, and hope you have already registered with the link, and you will receive your CPD certificates within the coming week. Thank you for joining. See you in 2 weeks' time.